Thank you. Thank you so much, Dr. Moreno. So before I start, I want to thank Dr. Sharma, Dr. Kinney, and Dr. Mehran for inviting me. I was here as a fellow not too long ago on the other side of the podium, assisting with all the live cases. So it's great to be back here. And I'm going to show you one of my worst left main PCI complications. Those are my disclosures. So this is the patient we had. She was a 71-year-old female. She's actually a snowbird who lives in Canada but has a winter home in California, spends her winters in Southern California. So she was here for the winter a few years ago, prior history of hypertension, hypothyroidism, COPD. She initially presented to a local community hospital with inferior ST elevation MI. She was emergently taken to the cath lab for PCI. This was the culprit lesion. So she had this mid to distal thrombotic occlusion. They put 3 drug-eluting stents extending all the way from the distal to proximal. They got pretty good result. So then they turned around to shoot the left system, and it turned out that she had very significant disease with severely diseased left main LAD, which were all very, very heavily calcified. So these were really just the 2 pictures that they took. So right after they took these 2 pictures, she went into VFib arrest. They had to defibrillate her, do 1 round of CPR. She was hypotensive after that. They put a balloon pump in, and they started her on norepinephrine. And then she was transferred to our hospital for consideration of complex PCI versus CABG. So when she came to our hospital, we did an echocardiogram. EF was around 45% with inferior and infralateral wall akinesis. So we had a quick heart team discussion. She was turned down for surgery. She was technically in shock. She was in SCAI stage C. She still had the balloon pump and was on norepinephrine when we got her. And of course, with the recent STEMI loaded on dual antiplatelet therapy, there was pushback from the surgeons about not wanting to take her to the OR. So in terms of PCI planning, really these were just the 2 pictures that we had. So right off the bat, given that amount of disease there was and the amount of calcium, which you don't really appreciate here very much, but on the actual pictures, you do see there's quite a bit of calcium in the mid-distal LAD as well as the left main. So we wanted to switch out the MCS to an Impella CP to get better hemodynamic support. We wanted to IVUS to decide the calcium modification strategy. And then the plan was to stent from the mid-LAD back to the left main ostium. Of course, we don't see the ostial circ here very well. So I just want to take a minute to talk about the guide catheter choice. My first choice was going to be a VODA catheter. So I first tried a VL35 catheter, then downsized it a little bit to VL30 because there was significant pressure dampening. But with both these VODA catheters, they were just kind of jumping and deep seating into the left main, causing significant hypotension despite the Impella. So at that point in time, I made a decision to switch out to a JL4 catheter. And then IVUS, like you can see, could not advance beyond that proximal LAD, but it did demonstrate that there was significant concentric calcification both in the prox LAD as well as the left main. So I then switched out the workhorse wire for a Rhoda floppy wire over a microcatheter, and this is a 1.5 millimeter rotablator burr that I used to do rotational atherectomy of the left main LAD. We went up to about 160,000 RPMs. And here you see atherectomy of the prox to mid-LAD. And at that point in time, the patient started saying, "Doctor, I can't breathe, I don't feel good." And usually when a patient who was thus far stable starts saying that, that's not a good thing. So right at that point, I also noticed that her systolic blood pressure had dropped down to the 60s, and she had complete loss of pulsatility on the Impella, which was a very significant change as compared to the beginning of the case. So I quickly walked the rotablator equipment out, and I took a picture, and this is what we had. This is the kind of picture, obviously, that causes the operator to have chest pain, not just the patient. Like you can see here, there's a significant left main dissection extending all the way back into the cusp, into the ascending aorta, and there's no flow down both the LAD as well as the circ. So now what? So the first thing I told myself is to keep calm. There were a couple of things that were going for us. First of all, the patient was hemodynamically supported with an impella, and secondly, I still have a wire down the LAD. So just with these two things, I was hopeful that I can salvage her. And I told myself that the two things that I don't want to do is not lose that wired position in the LAD and to not do any more unnecessary injections which would propagate the dissection and make things worse. So the immediate next step that I did want to do was to put a stent in the left main extending back into the aorta to seal off that entry point of the dissection. So before that, I did want to wire the circ. Before I stented across from the left main into the LAD, I wanted to wire the circ and at least get some flow going into the circ, because like I showed you, there was no flow down the circ. So with some maneuvering, I was able to get a Cheyenne blue wire to get into the circ, and I did balloon angioplasty of the circ as well as the left main into the LAD. And at that point, the patient's chest pain started to resolve and her blood pressure was back up to the hundreds. And then this is just to show the 3-5-23 drug-eluting stent that I deployed from the proximal LAD extending back into the left main. And this is a cranial view to make sure that we're actually covering the ostium and extending back into the aorta. And so just with deploying that stent, I was able to restore TIMI-3 flow down both the LAD as well as the circ. But unfortunately, our challenges were still not over. The poor guide support, I kind of briefly went over the guide choices that I had to go through. It came back to bite me. And at this point, even though we had done road ablation as well as done some NC ballooning of the prox to mid-LAD, I was not able to deliver anything, even with a guide extension. And I didn't want to push too hard because there is this stent in the left main coming back into the aorta. You don't want to cause longitudinal stent deformation. So at this point, I decided to switch out the guide catheter. And I did that by switching out the run-through wire to a more supportive wire. I used an Ironman wire, which I switched out with the help of a microcatheter, a long Ironman wire, and then I was able to get a Voda catheter, a VL35, under fluoroscopy. And once I got that in, the rest of the case was pretty straightforward. I put two overlapping stents, mid to proximal LAD, and then used IVUS to optimize these stents, 3.0 in the LAD and 4.5 in the left main, and the IVUS, which showed that these stents were pretty well expanded and well opposed. And finally, I took all the gear out, and I wanted to go back with a diagnostic catheter to really assess, what everything looked like, how the dissection flap was. So this is the final picture that I took with a diagnostic JL4 catheter. I left the impella in place, given that everything that the patient had been through, and she was in shock. These were her right heart cath numbers at the end of the case. CPO was 0.9. And the patient actually did very well. Impella was weaned off and explanted on day number 2. Her EF completely recovered. EF was 65%. She did have trace aortic regurgitation. We did a CT scan the following day just to assess the root and the ascending aorta, and I reviewed the images and reviewed it with the radiologist, and we really couldn't see any evidence of aortic dissection. The patient was discharged home on day 4, and she continues to do very well. Yeah. So a couple of quick learning points. Atherectomy of the left main does carry, ostial left main does carry a small risk of aortic dissection. Thankfully, these don't propagate, but they can cause closure, vessel closure. And the key is to avoid unnecessary injections, maintain wire access, and stent the left main back into the aorta. Some technical considerations to avoid this situation. I think we've talked about this during the course of the day. I think having coaxial guide engagement is very important. And if it was just the ostial left main, we could possibly consider a stiff rota wire. But in this case, there was the mid and proximal LAD, and you worry about wire bias. Possibly orbital atherectomy, where you're able to deliver antegrade under glide assist and then treat the lesion back in a retrograde fashion, could be considered, and IVL when feasible. Thank you.
Fantastic save. Very good work. Thank you so much.